Good evening, delegates. Thank you for joining Shield Connect. So, today we have a session on ovarian cancer screening, and the topic is going to be taken by Dr. Poonam Chandramathi from Karimnagar. So, before we start with the session, let me give a little introduction of our page Shield Connect. So, this is our page Shield Connect. You can log in through shieldconnect.in and you can find various sections are available on this page. First page is the blog section where you can find different blogs related to gynecology topics. So these are written by the speakers who are connected with Shield Connect. Then we have a webinar section where you can find upcoming and past webinars. So if you click on upcoming webinars, like if you click on see more, you will be able to see today's webinar. And here in the comment section, you can please post your queries in this comment section. So we can have a Q&A session with our speaker for the day. And we also have awareness pages like PCOS, menopause, GDM, COVID-19, thyroid, immune booster awareness pages. So if you click on any one of the pages, you will get the videos related to that topic. Then we also have 1 minute. Then we also have one more page, that is our leader section, where you can find all the key opinion leaders who are connected with Shield Connect. So you can also go through the brief profile of our speakers. So this is our page Shield Connect. And now let me give a brief introduction of our speaker, Dr. Poonam Chandramathi. Ma'am has done MS in obstetric and gynecology, masters in reproductive medicine, and currently ma'am is director of Sri Chandra Hospital from Karimnagar. Ma'am is also associate professor in CAIMS, Karimnagar, Telangana. Ma'am is certified in MRM course part 1 and 2 from Dubai and Cleveland Clinic Reproductive Medicine. And ma'am was ex-secretary of Karimnagar Foxy Society, and the special interest of ma'am is in high-risk pregnancy and infertility. So I welcome you, ma'am, on our platform for today's webinar. We are glad to have you on our platform, ma'am. Thank you, ma'am.
Okay. Thank you very much for my introduction. Good evening, everyone. Today, in this context of discussion regarding this ovarian cancer screening, we will be reviewing both the conventional and the novel approaches in the early detection of ovarian cancer and newer developments in the understanding of this ovarian cancer biology. So ovaries can be a site of variety of benign and malignant tumors. They can be cystic, solid, or combined, and the size can vary from 3 to 5 centimeters to a full-term pregnancy, and they can occur at any age, like from the adolescent to the reproductive age, or they can be manifested in the post-menopausal. And they also are of complex histological, have a complex histological origin. So before we go into further discussion, I would like to just have a brief note about the overall incidence and about these ovarian cancers. So the peak incidence of these epithelial ovarian cancers, most common one is the invasive epithelial ovarian cancers, is 60 years, and of which 30% of them are manifested in the postmenopausal women, and 30% of them are malignant. And in the premenopausal age, the risk of malignancy for these epithelial ovarian cancers is only 7%. And for the borderline tumors, it is 46 years is considered to be the average age of for the occurrence of this borderline tumors in a woman. So this ovarian cancer is associated with low parity and infertility, and at least one child birth will reduce the risk of the ovarian cancers. That is 0.3 to 0.4% of the risk reduction is being noticed with at least one child, and The occipils also will reduce the occurrence of the ovarian cancers. At least 5 years use of occipils will reduce 50% of the ovarian cancers. And the conventional approaches that have been in the past, like CA125, past and as well as in the present, the conventional screening approaches what we use for detecting these ovarian cancers, like CA125 and the transvaginal scan, do have a lot of false positive results. So newer novel screening approaches for the screening of these ovarian cancers have come into the consideration. And among these ovarian cancers, 10%, 5 to 10% are inherited genetically. That is, women with hereditary susceptibility, genetic susceptibility for these ovarian cancers, like those with BRCA1 and BRCA2 gene mutations, wherein we see the ovarian cancers to manifest at least 10 years before, when compared to those which are non-hereditary tumors. So any family, any woman with family history of these ovarian cancers, they should undergo a thorough full pedigree analysis, both from the maternal and the paternal side. And these genetically hereditary transmitted ovarian cancers have an autosomal mode of inheritance. So the surgical staging is not important here, but the stage of the disease is very important for understanding the prognosis, and as well as the subsequent treatment that has to be given to the patient. And many countries nowadays are practicing the protocol of opportunistic salpingectomy or prophylactic salpingo-oophorectomy, especially in the genetically predisposed women. And cytoreductive and debulking surgeries followed and by 2 to 3 cycles of chemotherapy are all known to us. So in the first 2 decades of a woman's life, the germ cell tumors, which are very fast growing, are common. Some, to name a few, are this teratoma, epidermal sinus tumor, dysgerminoma, and all these are the very fast growing ones when compared to the epithelial tumors, which are slow growing tumors. And coming next is the stromal cell tumors, which are of low grade, and they usually respond with adjuvant chemotherapy. And other forms of ovarian cancers constitute metastatic tumors, that is the tumors from the GIT and the breast, metastasis from the GIT and the breast. So here we see that histological classification of the ovarian tumors, wherein you see that the tumors can arise from the surface epithelium, which is the simple flattened surface of cell surface of the, which emerge from the simple flattened surface cell surface of the ovary, which is covering the entire ovary. And mostly these surface epithelial tumors will resemble the internal lining of the fimbrial end of the fallopian tube. So and those tumors are the serous tumors. So the surface epithelium tumors are the serous tumors, and coming next is the mucinous tumors, endometrioid tumors, clear cell, and transitional tumors. So the endometrioid tumors have the histological appearance similar to the uterine endometrium, and the mucinous tumors have the histological picture resembling the endocervical glands, and the clear cell tumors, which constitute around 6%, resemble the vaginal cell rest, that is resemble the Mullerian origin. And these epithelial ovarian tumors are again grade 1, grade 2, grade 3, and grade 4. Of course, grade 1 is the low grade. Grade 2 and grade 3 and 4 are considered to be the high grade tumors. And non-epithelial ones are the germ cell, which arise from the germ cells from the ovarian follicle, like the dysgerminoma, endodermal sinus tumor, embryonal carcinoma, teratoma, and other germ cell tumors. And ovarian cancers also arise from the stroma, and that is a sex cord. So these are the granulosa cell tumors, sertoli Leydig cell tumors, theca cell tumors, fibroma, and other sex cord stroma tumors. So the most common of all here is the epithelial cancer. So most common ovarian cancer, which constitute around 90%, and it is primarily originated from the primary is from the ovary, 80%, and 20% are metastatic from the breast, GIT, and the colon. So mean age of the diagnosis is 60 years. That is advanced at a later age, and at an advanced stage, it is usually diagnosed. There is an effect of menopausal status, and 30% of the ovarian neoplasms are malignant in the postmenopausal women, and only 7% are malignant in the premenopausal. So there are various etiologies and various theories to understand this ovarian cancer biology. So there is no particular etiology. It's not very well known, but one protocol, that is the fallopian tube theory of ovarian carcinoma protocol, carcinogenesis, is being like accepted by many of the pathologists, and they are following this CFIM protocol, that is sectioning and extensive examining of the fimbrial end. CFIM protocol is being practiced, protocol is being observed by many of the pathologists, and they believe that there is a theory called fallopian tube ovarian carcinogenesis theory. And another theory is the hereditary or the familial ovarian cancers in case of genetically predisposed women, wherein they have BRCA1 and 2 mutations, RAS oncogenes, and those with P53 mutations. And of course, here I would like to add some more studies which show that mutations in the Lynch syndrome, that is mismatch repair, that is HNP-LCC, that is hereditary non-polyposis colon cancer syndrome, wherein MLH1, MSH2, MSH6, and PMS2 gene mutations also have been noticed. So in this hereditary or familial ovarian cancer history patients, many of the countries are counseling and offering an opportunistic salpingectomy, for and as well as this salpingo-oophorectomy in this hereditary predisposed women to avoid further advanced stage of malignancy. There are so many ovarian cancer screening trials also has been done, which we'll be discussing later. So the risk modifiers come when you look into the risk modifiers. The risk factors are nulliparity, infertility, early menarche, late menopause, endometriosis, family history of ovarian cancers, talc use, prolonged use of ovulation-inducing drugs, HRT, are some of the risk factors wherein women with all these history are predisposed to the ovarian cancers. And some protective factors are the use of ossipils. But recently there are so many newer formulations of ossipils. There is no study trial saying that even they have a protective effect over these ovarian cancers. But the combined pills which were used previously definitely had have a protective effect in preventing these ovarian cancers. And of course, pregnancy, breastfeeding, tubal ligation, those who have undergone hysterectomy and prophylactic salpingo-oophorectomy, they do have lesser incidence of ovarian malignancies. So in this slide, we see the WHO classification of the epithelial ovarian tumors as classified in the year 2003. So here they have classified the epithelial tumors into serous adenocarcinoma, mucinous tumors are the adenocarcinoma, pseudomyxoma peritoni, mucinous pseudomyxoma peritoni, endometrioid tumors. Among the endometrioid tumors, it is adenocarcinoma and mixed Mullerian tumor. And clear cell adenocarcinoma, transitional cell tumors. In the transitional cell tumors, we see a Brenner's tumor and transitional cell carcinoma. And some of the rare epithelial tumors are the mixed carcinoma, undifferentiated, small cell carcinoma, and squamous cell carcinoma. So here in this picture, you can see this is a mucinous tumor with blood vessels present on the surface, and it is indicating that it is a very vascular one. And to the left, you will see this, you're seeing this specimen of uterus and ovaries, where you see multiple papillary excrescences and papillary projections in the cut section. So each type of epithelial tumor has its own typical histological features. So here in this slide, we'll be seeing the frequency of these epithelial tumors and what are all the histological features specific to that particular epithelial tumor. In the serous epithelial tumor, as I've already mentioned, it is the cellular histopathology cell type resembles the lining of the fallopian tube, and the frequency of occurrence is about 80%. And the characteristic feature to identify this serous epithelial tumor is the presence of xanthoma bodies, which are frequently found in these tumors, which are nothing but concentric rings of calcification, which are caused by the apoptosis of the tumor cells, and the osteoinductive cytokines are being introduced into it by the macrophages, and they create this look of concentric rings of calcification. And the mucinous, coming to this mucinous epithelial tumor, wherein the cell type, the cellular type, the histological cell type is similar to the endocervical lining, and these the cells produce a lot of mucin secreting cells, you can see here, and the frequency of these epithelial tumors is 10%. Coming to the endometrioid type of epithelial tumors, wherein the lining is the endometrium, where endometrial resembles the lining of uterine endometrial lining, which the frequency of occurrence is only 10%, and it is mostly very well differentiated epithelial tumor. In a clear cell tumor, wherein you see the Mullerian type of histology, histopathology, and the prominent feature in this is the clear cell or the hobnail cell, wherein you see the like the nuclei are pushed to the apex. Nuclei pushed to the apical cytoplasm is one of the interesting histological finding. And this is very rare, which is seen in only less than 1%. And coming to the transitional cell type of epithelial tumors, you see the transitional cells. It resembles the like the lining of the bladder, and wherein you see a dense, abundant fibrous stroma is seen in this, and interspersed in this are the nests of certain nests of the transitional cells, which are called as the Walthod cell rests, which have a longitudinal groove, and they have an appearance of the puffed wheat appearance in this. So these are some of the interesting features which we come across in the histopathology of these epithelial tumors. And they do have a very distinct clinical behavior irrespective of the histology. Like as I already said, these epithelial ovarian cancers are divided into low grade, high grade, and borderline. The low grade tumors are usually the serous and the mucinous, and the mucinous sometimes is associated with pseudomyxoma peritoni, and these are highly responsive to the chemotherapy, and they have long time progression free survival time is noticed. And in the low grade tumors, usually are associated with BRAF and KRAF mutations. And the high-grade epithelial ovarian cancers are the invasive cancers, where they are highly invasive. They are come under the grade 2 and grade 3, and they are usually associated with these P53 mutations, and they have very poor prognosis. And the borderline ones are constitute around 15%, and these are mostly manifested in premenopausal period, and sometimes the borderline can be metastatic as well. So coming to this histological grading of any ovarian neoplasm, each one has it's a distinct histological pattern. And this histological grading is very important to assess the prognosis and to identify the malignancy. And some criteria like nuclear atypia, cellular pleomorphism, stratification, mitotic count, and the proportion of the solid areas that are present within the tumor, all these are taken into the consideration for a histological grading of any ovarian neoplasm. And recently, this flow cytometry of the tumor DNA is another method which is useful for assessing the tumor prognosis. So how do you screen these patients? So ovarian cancer screening. So cancer screening, the methods are the annual pelvic examination, pelvic ultrasound, that is a transvaginal ultrasound, and assessing this serum levels of CA125. So CA125 and the serum proteomic screening, multimodal screening, and all these are some of the methods for the ovarian cancer screening, but none of them is so reliable and cost effective in the general population. And those with familial ovarian cancers with BRCA1 and 2 gene, prophylactic salpingectomy or prophylactic occipils have been advised. So what is this CA125, which we commonly measure in usually CA125? This is a very important is a tumor marker for identifying ovarian malignancy, which is nothing but it is a high molecular weight glycoprotein, which is a heavy glycosylated high molecular weight glycoprotein, which is a transmembrane cell. It is produced is a transmembrane cell surface protein, which is produced by these human epithelial ovarian cancers, and it is normally also produced by the lung, cornea, and the endometrium. Normally also produced by the lungs as well as in the cornea and the endometrium, and it is shed into the body fluids, and it is cleaved and it will be shed into the body fluids, and we can detect it by the immune assay. So that's how this CA125 has its importance in diagnosis of the ovarian cancers. So the another screening method is by Doppler ultrasound and fallopian tube cytology, and there is some one method which has been popular, like Pap-seq test, where you do the endocervical brushings and you collect the proximate tumor fluids. So sometimes, like the tumor cells are being shed into the body fluids. That's why you do a Pap smear, Pap-seq test, and combined with this CA125, and you collect the proximal tumor fluids, and by, for example, examining the tampons of the woman, collecting them, and you look into the cancer cells into these. And of late, in this past 2 decades, there are so many protein biomarkers. I can say around 110 biomarkers have come into consideration for the early detection, and which are highly sensitive, cost effective, and highly specific in diagnosis of these ovarian cancers, and are highly promising. And their two-stage approach strategy is being considered. that is rising levels of blood biomarkers and prompt imaging. These are the two-stage approaches are being considered in these ovarian cancer screening. So these biomarkers which are being measured these days can be measured individually, or they can be combined with CA-125. So there is another protein biomarker like human epididymis protein, that is HE4, which is highly elevated in epithelial ovarian cancers, and another glycoprotein, that is CA72.4 glycoprotein, which is helpful in detecting of these epithelial ovarian cancers in those conditions where the cancers are being missed by the CA-125 and HE4. The CA72.4 detection has been very useful in the early detection of these epithelial ovarian cancers. And there are several autoantibodies. So these autoantibody detection is also one of the method, the novel approach for the detection of these ovarian cancers, because the small volumes of even they are able to detect very small volumes of ovarian cancers at least 2 to 3 years before they progress into a high grade tumor. So these autoantibodies like TP53 antibody, anti-homeobox gene A7 antibody, anti-interleukin 8 autoantibodies, these are all found to be elevated in case of ovarian epithelial ovarian cancers, and all are we can detect them in suspicious patients at least 22 months before, when compared to the elevated CA-125. Apart from this, there are microRNAs and circulating DNAs, and which is highly sensitive. And these microRNAs and circulating DNA also form one of the cancer-seq panel, wherein which is useful for early detection of these ovarian cancers. And because the early detection, we can prevent the patient to develop, and we can halt the progress of the disease. So coming to the imaging modalities, MRI can as well detect the early ovarian cancers, and there is another advanced technology like magnetic relaxometry, which can detect small portions of the cancers without causing any ionizing radiation to the patient. And there is another novel approach called SQUID technology, where which is superconducting quantum interference device. With this, there are nanoparticles which go and directly bound to the cancer cells, and by measuring the unbound nanoparticles, we can assess the tumor volume. So these are few of the novel approaches for ovarian cancer screening. So coming to the clinical features, the symptoms what we usually see, patients come with the symptoms like some of them are asymptomatic, some have anorexia, weight loss, abdomen pain, distension, bloating, and on palpation we can find an irregular mass. They have dyspnea if there is any, because of the size of the tumor, and then sometimes they have nausea, constipation, bowel disturbances, and urinary frequency. Increase urinary frequency disturbances also can be noticed. The signs are like we can see an ascites, lower abdomen mass, pelvic mass, and an ultrasound can detect an omental cake, and we can also see the nodules in pouch of ductless, and per rectal examination is also we can identify the tumor. There are several diagnostic criteria of these ovarian cancers. So ultrasound, coming to this ultrasound, wherein you can measure the ovarian volume, where you find the ovarian volume is more than 10 cubic centimeters. You can see the solid areas, cystic areas, the complicated ovarian cancer. You can see the multiloculated appearance and a multiloculated or unilocular pattern. of the ovarian carcinoma. You can as well measure the thickness of the cyst wall, which is usually more than 3 millimeters, and the septum thickness of the septum, which will be more than 2 millimeters, and usually it is bilaterality, papillary excrescences. All these features can be picked up by the ultrasound. And coming to the Doppler flow studies, you will see there is an increase in the vascularity, and the resistance index is less than 0.04, and pulsatility index will be less than 1. And of course, measuring of these tumor markers like CA125, HE4, and inhibin are some of the diagnostic criteria for these ovarian cancers. So there are some tumor markers which we come across in the germ cell tumors, like in this germinoma, you see that there is an elevated LDH, and that is lactic dehydrogenase, and also elevated HCG. In the yolk sac tumor, you find there is an increase in the elevation of the alpha fetoprotein, and in the embryonal cell carcinoma, you will find an increase in the alpha fetoprotein as well as the HCG. And choriocarcinoma, there will be highly elevated, which is diagnosed by the highly elevated HCG levels. So there is a diagnostic differentiation of the ovarian tumor on ultrasonography, and there is a group called as International Ovarian Tumor Analysis Group, and they have a rules, that is the IOTA rules. IOTA rules, where the benign tumors have B rules, malignant tumors have M rules. In the benign tumor, B1 is where the tumor is unilocular, and B2 where there is presence of the solid components and the diameter is less than 7 mm, and B3 wherein you find acoustic shadows, B4 where you see smooth multilocular tumor with the largest diameter of less than 100 mm, and B5 where there is no blood flow and color score is only 1. So in the malignant, if there is a malignant tumors, the M rules are M1 where you see there is irregular solid tumors, M2 where you see the presence of ascites, and at least M3 where there are at least 4 papillary excrescences, M4 where there is irregular multilocular solid tumor with diameter of more than 100 millimeters, and M5 where you see a very strong blood flow with color score of more than 4. So these are the IOTA rules, and as per IOTA rules, if one or more M rule applies in the absence of B rules, it is malignant. If one or more B rules apply in the absence of M rules, it is benign. It is named as benign. And if both M and B rules are there, it is not classified. And if no rules are applied, it is unclassified. These are certain rules as set by the IOTA group. So other diagnostic methods here are the CT scan, where it detects the disease up to 1.5 to 2 centimeters, MRA, which will detect the disease of more than 1 centimeter, PET scan for the distant disease, and of course by paracentesis, FNAC, and confirmation of the cytology or tissue diagnosis by the surgical specimen. So risk assessment in an ovarian tumor is very important. So the risk assessment is by morphological index, risk of malignancy index, serum biomarker levels, color flow levels, and the color flow Doppler and the serum proteomics. So the risk of malignancy index as per RCOG guidelines is detected by score is detected by formula, that is risk malignancy index U into M into CA125. The U is nothing but the ultrasound score 013, where the score of 0 or 1 or 3 is scored as per the multilocularity, solid areas, metastasis, ascites, and bilateral lesions. And M score where the pre-menopause is score 1, post-menopause is score 3, and the risk of malignancy index is said to be low risk if the risk is below 25, and 25 to 250 constitutes moderate risk, and more than 250 shows there is a high risk of malignancy. This is all as per RCOG guidelines. So this slide shows the PIGO staging of ovarian cancer, where stage 1 is the growth limited to the ovaries, limited A1A, that is limited to one ovary, no tumor on the surface and negative washings. 1B is growth in ovaries, same as 1A. 1C is tumor limited to both the ovaries, and 1C1, where you see the surgical spill. 1C2 is the tumor rupture before surgery or tumor on the surface. 1C3 is the malignant cells found in the ascites and peritoneal wash. And stage 2 is growth involving one or both ovaries with pelvic extension. 2A, where the extension or the metastasis to the uterus and the fallopian tubes. 2B being the spread to the bladder, rectum, and the sigmoid colon. 3A is the positive retroperitoneal lymph nodes and the microscopic metastasis beyond the pelvis. Stage 4A is the pleural effusion with positive cytology, and 4B is distant metastasis to the hepatic liver, hepatic splenic parenchymal metastasis, and to the extra abdominal organs and the lymph nodes. So these are all the risk factors which reduce the women's risk of developing ovarian cancers. And this table shows the lifetime risk associated with the tumor specific genes, like this the percentage in BRCA1. The risk of breast cancer is more, and the risk compared to the ovarian and the endometrial cancers. And in patients with hereditarily predisposed to the breast cancer in BRCA2, the incidence is more, and the incidence of ovarian cancer is only 15 to 25% in the patients with BRCA2 gene mutation. And the risk of endometrial cancers is more in the mismatch repair, that is the hereditary non-polyposis colon cancer syndrome, where you see the risk of endometrial cancer is around 40 to 60%. So cancer susceptibility is definitely more in patients more prone for with the ovarian and the breast cancer can occur together, and the can be also be associated with the bilateral breast cancer, and there can be ovarian and the breast cancer in the same patients. And Jewish ancestry have reported to have 2% chance of the ovarian cancer susceptibility is being noted in them. And male breast cancer is also present in men with BRCA1 and BRCA2 hereditary gene mutations. So the natural history, precise natural history is poorly understood, and there is no direct evidence for any pre-malignant lesion in the ovarian cancer. The entire peritoneum is at the risk of developing peritoneal carcinomatosis, and which might develop even after an oophorectomy. So there are several screening ovarian cancer screening tests which are done for the general population, like this PLCO trial, where they have considered studies in the prostate, lung, colorectal, and ovarian trial, where they have studied around 68,557 participants of 55 to 74 years of age with previous history of oophorectomy. And but these have there were so many false positives in this study. And there is another UK study, that is UK study of collaborated with ovarian cancers, where they have studied women and with annual CA125 and the transvaginal ultrasound in different phases. So the major organizations usually do not recommend ovarian cancer screenings because of the poor understanding of the natural history, and no survival benefit is being demonstrated in the high risk group. And and of course the bilateral salpingo oophorectomy is considered to be the standard care for those BRCA1 and 2 carriers, which will reduce the risk of ovarian cancer by 75 to 96%. And the countries which have taken up the bilateral salping oophorectomy in BRCA carriers are Australia, UK, France, and Canada. So how do you manage, coming to this management of ovarian cancers in the early stage, that is early ovarian cancer stage 1 and stage 2, is surgical staging and debulking, and ascitic fluid examination for cytology and peritoneal washings, doing a total abdominal hysterectomy, bilateral salping oophorectomy, which is a protective surgery to them, and omentectomy and pelvic and para-aortic lymphadenectomy, along with multiple peritoneal biopsies to know the staging. And adjuvant therapy in early stage disease, that is those with low risk, that is stage 1A, grade 1 and grade 2, there is no adjuvant therapy is required. But stage 1A, grade 3 and stage 1B2, these are high risk where they definitely require 3 cycles of chemotherapy. In the advanced stage diseases, that is stage 3 and stage 4, they require 3 to 6 cycles of chemotherapy. And the standard combination for the advanced stage of ovarian carcinoma is carboplatin and paclitaxel standard combination. And management of advanced stage epithelial ovarian cancers is by staging laparotomy and primary cytoreductive surgery, followed by postoperative adjuvant chemotherapy. And best results are seen in those with nil residual disease, and debulk to the microscopic level should be the concept in the debulking surgeries. And for inoperable cases and the high risk surgical risk cases, neoadjuvant chemotherapy followed by surgery and postoperative chemotherapy is considered. And subsequent management in those with complete response, you have to do a follow-up, and those with partial response continue again the same chemotherapy, switch to a second line chemotherapy, and those with stable disease switch to the second line chemotherapy, and those with progressive of the disease switch to the second line chemotherapy. And second line chemotherapy and other modalities that have come into the treatment modalities, newer treatment modalities are the immunotherapy, hormone therapy, gene therapy, radiation therapy, high dose chemotherapy, and autologous bone marrow transplantation, and newer drugs like docetaxel, topotecan, doxorubicin, gemcitabine, etoposide, ifosfamide, tamoxifen, and also some more newer drugs have come into the consideration, like trabectedin and NAB paclitaxel, that is nanoparticle bound paclitaxel albumin, and pegylated liposomal doxorubicin, that is PLD. And there is Avastin, a drug called Avastin, that is bevacizumab, which is not a chemotherapy drug, but it is a human anti-angiogenic monoclonal antibody. It is a human anti-angiogenic monoclonal antibody to the vascular endothelial growth factor, which will prevent the angiogenesis and reduces the tumor load. And but this is quite expensive, as this has to be used for at least 20 to 21 cycles, and it is very expensive. And after these chemotherapy and cytoreductive surgeries, they have to be followed up very carefully, at least for 3 months, for 2 years, 4 to 6 months for 3 to 5 years, and annually for 5 years. And clinically, also we can follow up, and with tumor markers like CA125 and CT scan for in case of suspected recurrence. So with this, I end this today's topic of ovarian cancer screening, and I hope it must be of some use to all of you to brush up your previous knowledge with coming to this ovarian cancers.
Thank you, ma'am, for
okay, thank you very much,
yes,
Shield Pharma, for giving me this opportunity.
So let me check if we have any queries from the our delegate section. One minute. So, ma'am, I received one question. How can we prevent false positive results during ovarian cancer screening?
Yeah, false positives can be avoided by by not sticking on to only a single biomarker. So there should be combined. It should be a combined serum biomarker with CT scan and ultrasound, Dopplers. See, there should be a multi diagnostic criteria should be taken into consideration. So this is how we can prevent. We should not go with a single test. So there should be a combined screening model, combined diagnostic criteria should be taken into consideration.
The second question is when when is the genetic test recommended for ovarian cancer detection?
Yeah, genetic test is not frequently advised for every woman, but those with suspicious family history, those
Yes.
who are familiarly predisposed with history of ovarian cancers, like grandmothers, fathers, and
Yes.
those with family history, we have to take a complete pedigree analysis, both from the maternal and the paternal side. And then they are, suppose those individuals are should go for a genetic screening, and if there is any slightest detection, then they are advised prophylactic salpingo-oophorectomy once they complete the family life, because the grade 1 and 2
Yes.
tumors on long standing, they undergo certain transformations and their genetic mutations, and at a later stage they become malignant. So the precursor lesion has to be identified, and in case if there is any genetic susceptibility, she has to undergo this gene testing.
There is one more question that which is the most common gynecological cancer in the woman? Most common one, which can be from which we can recover also.
Which is the most
Common gynecologic cancer, like cervical cancer or ovarian cancer.
Yeah, it is cervical cancer. Cervical cancer. So the next comes this ovarian malignancy.
Regarding cervical cancer, only pap test screen is to be done for cervical cancer, or can we also do HPV test along with pap?
Yeah, of course, HPV and even pap smear and endocervical brushings and endocervical brushings and pap seek test, and there are so many latest like innovative pap tests, like liquid pap. These have all come into consideration, and early detection can be done by doing all these tests.
Thank you, ma'am, for giving all the answers to these questions of delegates. And we are very glad to have you on our platform, and we would like to have more informative sessions with you on our platform in next.
Okay.
Yeah, thank you, ma'am.
Thank you, ma'am.
This is thank you so much, ma'am. This is one of the best webinars actually happened in a Shield platform, ma'am. Like the topic that the topic the topic, the delivery and everything is like best, one of the best webinars, ma'am. Out of more than 1,000 webinars we have conducted, but one of the stands as one of the best webinars actually we have conducted. Really grateful, ma'am, for that.
Thank you so much. Thank you so much. No?
I
look forward in your association for a long time.
Thank you so much, ma'am.
Thank you, ma'am.
Ma'am, good evening. Prasad, ma'am.
Hello. Good evening, Prasad Garu.
Ma'am, good evening, PV Prasad.
Prasad Garu, thank you for being present.
Thanks so much for accepting.
Thank you so much.
Right. And thank you all participants also for being with us. Thanks, ma'am. Thanks so much.
Thank you, ma'am. Thank you so much. Bye, ma'am.
Bye. అయిపోయింది